Here we are at the bottom of week 10 or halfway through week 10, right? We have chapter 14 that we're covering general anesthesia, and chapter 15 was your mini session on emergency situations. I am going to put the link just in case anyone has not had the opportunity to watch it. Okay, so that is the actual YouTube link. We have 4 questions from that mini session that we're going to be going over this evening. And we have a Kahoot game. Now, everything is going to help gear you up for this cumulative final exam. If you'll notice, your review or study guide is already up. It's penned underneath, so it's like the last top pen, and there is a Quizlet attached to it. I highly encourage you to use it as an additional resource. That means still go back, read your sources. I'm still checking, getting word back about seeing about previous quizzes, trying to make sure or if you're allowed to see those. So just keep that in mind as well. Okay. Now, general anesthesia. Okay. So we know this is what we're going to be talking about. But in your mini session, we had chapter 15. We were talking about emergency situations. So what we're going to do is you're going to make an educated guess if you had not had the opportunity to watch the archive, or not the archive, the mini session. And if you have, tap into what you think the correct answer is. So for this very first question, which of the following statements is true regarding the management of mild allergic reactions and the potential escalation to anaphylaxis? So A states H1 and H2 receptor antagonists like Benadryl should be used for anaphylaxis as they effectively reverse severe allergic reactions. Or B, if early signs of mild allergic reactions, such as skin redness or hives, appear, potential triggers should be stopped immediately to prevent escalation of anaphylaxis. So, as you're looking at these 2 questions, and as you notice, I grabbed 2 potential answers that you could see why one or the other could be correct. But in the operating room, I want you to think outside of the box. Are you able to provide Benadryl? Probably, right? Are you able to stop whatever is going on with that patient immediately? So, in front of you, you have A, giving medication like Benadryl because you do want to reverse severe allergic reactions, or B, you are stopping immediately whatever potential trigger it was to prevent the escalation to anaphylaxis. So, A or B. I love it. So I have 2 that have typed in the correct, 3 that have typed in the correct answer so far. Yes, yes, and yes. Anyone else want to take a hint? And I love that you guys are sending it to me directly, because then it allows other individuals to kind of get their answers out there as well. Okay. So the ones that are answered so far, the answer is B. And it's because mild allergic reactions, including skin redness, hives, or raised patches, should be promptly addressed by whatever the potential trigger is. Remember, we're not really sure. So we're going to stop everything that we could potentially think could cause this patient to go into some type of anaphylaxis. Okay. Here's another question before we dive into general anesthesia. In a cardiac arrest situation during surgery, which of the following responsibilities would most likely fall under the role of the scrubbed surgical tech? A, administering medications and ensuring the crash cart is stocked with necessary supplies. Or B, maintaining the sterile field, assisting the surgical team, and helping with equipment readiness for emergency use. I already see correct answer. One correct answer so far. And remember, it's okay to guess, right? I see two correct answers so far. 3, 4. Okay. The correct answer is B. Our job, unless we are told otherwise, is to maintain our sterile field. We're still going to help the surgical team. We're still going to help with equipment readiness for emergency use. However, per the book, right, we're going to stay sterile. We're going to keep our field sterile. So, good job for those of you that jumped in and kind of got out there. All right. Tons of learning objectives from abbreviations. We're going to have a list of terminology that it's going to be really important for you to understand and differentiate and compare and contrast. We are going to look at the anesthesia equipment. Now, as a surgical tech, 9 times out of 10, unless you are at a surgery center, you're not going to really touch the anesthesia cart. However, there may be times where, let's say, anesthesia is short-handed. And so anesthesiologists before a case may say, hey, can you locate this? It has happened where I've had to go to the back 40 or the back area where our supplies are and go into the anesthesia workroom to help out my anesthesiologist in between cases just because, they were short-staffed. And in the surgery centers, we are actually the ones kind of really helping with anesthesiologists because, at least at the surgery center I was at, we didn't have an anesthesia tech. So small, a little bit smaller. So you do have a lot more hats. Okay. We're also going to explain basic components of general anesthetic, looking at inducing general anesthesia and looking at the phases, as well as airway management and steps in the process of endotracheal intubation. Tons of terms. Okay. It's going to be really important to be able to differentiate a mixture of two liquids that don't fully blend, that is common in pharmacology, like emulsions, right here, versus something like, what is it called when we remove the ET tube after use? Extubation. So you've probably heard me during different lectures talking about intubation, extubation. Make sure you know the difference. Okay. That's not all the terminology. Besides this slide, there's a little bit more. We talk about MACs, PACU is that post anesthesia care unit where the patients, they go after they leave us. Okay. We look at RSI, rapid sequence induction. This is a technique used for patients at higher risk of aspiration, such as those that naturally have a gastric reflux. All of the terms in both slides is going to be important to understand as you're gearing up for the next days of the program. You're going to be getting ready for lab, which I know you're excited about. You're going to be really diving into not only anatomy and physiology that you've had, but breaking it down to actual surgical procedures that you're probably going to be in a couple times throughout your career. When we talk about the basics of anesthesia, we look at the pain impulse transmission. We have what's called our nerve endings, okay? These detect pain and then send signals through your nerves. Pathways that carry pain signals to the spinal cord are the nerves. So you have your nerve endings that are going through the nerves that are carrying pain signals to the spinal cord. When we look at sensory and motor nerves, They send pain signals to the brain, and then motor nerves control the movement. It's like you are touching a hot stove. You didn't know it was hot. The receptor goes to your brain, tells you, hey, that's hot, that's pain, and then you move your hand. One of the other classes that I taught, we talked about patients that did not have a sense of pain. And I would always ask them the question, would you rather live a life without any physical pain? And it was very interesting to kind of hear the thinking. And then I would share that a lot of those particular patients are prone to accidents, are prone to serious injuries. Why do you think that is when we talk about sensor and motor nerves? And you guys can type it in. Like, why would a person who does not feel pain at all be more susceptible to actually being in more harm? They would not be aware that something is wrong. That is correct. A lot of times, those patients, especially as infants, when they can't feel pain, and a lot of infants and babies, when they're learning, it's when they touch something and it hurts, and they're like, I can't do that again. But if you have a baby, an infant, toddler, who never had the experience, right, of pain, they're not going to know to stop. We get into our spinal cord. That is that relay station. It's passing the signals from the nerves to the brain. So for us, our brain is like, take your hand off of the stove, that's hot. But for patients that don't have a pain sensation, they may have their hand on there until someone's like, what is that smell? And then they're going and taking the hand off. So from the spinal cord, goes to the brain, and then the brain interprets the pain signals, and that's how that sensation of pain is created. Pain begins when nerve endings detect a harmful stimulus. Signals are sent through sensory nerves, again to the spinal cord, and then there's what's called a motor loop. The spinal cord processes the signal, potentially triggering a reflex response. Signals reach the brain, where again, pain is recognized, and then a response is decided. So, what does this have to do with us in general anesthesia? When we look at systemic anesthesia, this is going to affect the whole body rather than a specific area, like the hand that's touching the stove or a site. Maybe, with a local anesthesia, we're just doing a shoulder block. Now, this is how it works. It prevents the brain from interpreting pain signals from anywhere in the body. So, in essence, you are that patient for that time frame that does not feel pain. Okay. It's ideal for surgeries with multiple sites or areas that are hard to block regionally. So that's when we get into those big belly cases, because there's no way and not enough anesthetic to be able to inject. Let's say you have a huge belly case and you're going deep into the belly. We're pulling out intestines. We're running the intestines. Yes, we do take it out of the body and actually run it, where we're taking, and the doctor will literally take out the intestines and run it. There's no way to be able, with a local regional block, to give enough pain relief, even during surgery. So they're going to be under general anesthesia. Now, we're going to be using general anesthesia for skin grafts. Oftentimes we have dual sites, breast reconstructions, autologous bone grafts, especially in ACLs, because we're taking sometimes the patient's own tendon and moving it to give them a new ACL. Two main factors determine if general anesthesia is going to be appropriate. We look at the actual procedure. Is it needed for surgeries involving multiple areas? We just mentioned skin grafts, we just mentioned breast reconstructions, etc., right? Or used for long surgeries. You have a transplant. We're not giving a patient that's getting a transplant any type of local nothing, okay? And then we look at the patient factors: age, mental state, emotional readiness. That also includes patient preferences. They matter. If they fear needles or they're anxious, sometimes the doctor will be like, okay, we're going to lean more towards general anesthesia anyway. This really does help patients feel more comfortable and meet the needs of those extremely complex procedures. So the cart, called the anesthesia cart. Again, do not let this intimidate you. There is going to be an anesthesia tech, especially at bigger hospitals. Now, unless you're going to a smaller same day surgery, it may be different. Not saying that some don't have them, some have money. They may have the ability to have someone specifically in charge of anesthesia or the anesthesia cart. But you have the components of the anesthesia workstation. Everything from manual, automatic ventilation systems, we have breathing circuits, we have our oxygen, nitrous oxide, you have pressure regulators, gas mixing systems. There's a few key features, okay? Alarms alert when it's ready to go beyond preset limits. There are goals of general anesthesia. We want to prevent awareness during surgery. We also want to prevent memory of the procedure, as that could be very traumatic as well. And we want to ensure the patient remains still. You don't want someone moving around. It's like a moving target. That's not going to be good, especially if you're in a very complex, let's say, spinal case, right? Where any brief movement, even from us, could be extremely dangerous and debilitating for a patient. Again, we want the patient unaware, and we want them to not respond to a bovie cutting vessels, cutting their skin. We also want them to feel no pain. We also want them to not have recall. And again, just reiterating that we want to make sure they remain still. Now, there are a lot of methods of general anesthesia. Intravenous, the drugs are delivered directly into the bloodstream. We have inhalation, which is the one we normally do, where gases and vapors are inhaled through a mask or a tube. And then sometimes we combine them. So that's called balanced anesthesia. And we combine the IV and the inhalation methods, and that just gives a very optimal effect. The less common approach, the chapter tells us, is a regional block, may be used with a light general anesthetic, typically for patients that are at high risk. Keep in mind, this approach is rare, but can provide additional safety in specific cases. And that's going to be on a case by case basis. I won't be able to tell you, we're going to definitely, in this particular case, do this less common approach. A lot of factors. Goes back to patient's age, the procedure, yada, yada, yada. Okay. Now, we look at the phases of general anesthetics. We're going to break these down. Okay. We're starting off with pre-induction. This starts when the patient is admitted to the preoperative holding area. I repeat, I have seen this question before. This starts when the patient is admitted to the preoperative area. This is where your patient is being evaluated for their health, their readiness for the actual surgery. The patient's getting ready physically, physiologically, psychologically. You're moving the patient to the actual operating room. They're giving oxygen before anesthetics or anesthesia. And then they start to administer the anesthetic agent to begin the induction phase. Pre-induction sets the stage for a safe and hopefully smooth transition into anesthesia. Now, in the induction phase, some anesthesiologists may say quiet on deck. They may say quiet. It depends on that anesthesia provider's comfortability with the case again, and what other issues the patient may have. Now, this starts when the anesthetic medications are administered to initiate general anesthesia. It concludes when the patient reaches an adequate depth of anesthesia and their airway is secured. And what I mean by depth, the level of unconsciousness that the patient is in. Okay, think of it as, are they in REM sleep? Granted, we're putting them in under general anesthesia, but kind of like deep. Okay. With that, we talk about airway management because the airway has to be secured. Okay, so masks, they're just placed over the patient's nose and mouth. That way, oxygen and different inhalation agents are inhaled. It is suitable for, let's say, short procedures like myringotomies. Remember, I told you those are real quick 10-15 minute cases, and tubes, because all we're doing is taking a myringotomy knife, super small, giving it to our surgeon. They make the incision, you give them the PE tube, they stick it in, put some drops, some cotton, surgeon's preference, and we're done. Granted, we're still using the microscope. Microscope comes in and out, but that's like the longest part, is bringing that microscope over for the surgeon. Okay. And the mask really does support respiration, which is just that oxygen exchange during surgery without much muscle relaxation. We look at a laryngeal mask airway, or LMA, and this is going to sit on top of the larynx, delivering oxygen and, again, anesthetic agents, again, for short cases. But it is counterindicated, which means not recommended for oral surgeries, obviously, because you don't want anything in the mouth. Obesity, because a lot of times they may have issues like sleep apnea or other issues with breathing. Hiatal hernias, GERD, or low pulmonary compliance. And then there's the ET tube, which we're going to see in the next slide, provides a maximum airway control. It is used for longer surgeries, deep muscle relaxation, or when the patient is prone, like if they're on their stomach or in a lateral position on their side. All right. Here is the ET tube. Okay, you can see where it goes. It's inserted through the patient's mouth and into the trachea. You'll notice that the surgeon or the anesthesiologist, CRNA, they're going to have their stethoscope as soon as they put in the tube just to check placement, making sure they can hear the lungs expand. They measure the CO2 levels just to confirm that it is in the correct placement. Okay, so that's the first half. In the second half, we have quite a little bit more to kind of cover. We're going to look at the maintenance phase of the surgical procedure. We're going to look at emergence phase. We're going to identify major categories of anesthesia medications, look at IV induction agents. Not done. We have to look at opioids that are used for analgesics and inhalation agents, purposes, their disadvantages, neuromuscular blocking agents, depolarizing, non-polarizing muscle relaxants, and then finishing up describing reversal agents for various anesthetics that has to be ready to go. The induction phase. We hear patient sensitivity a lot. Patients are highly reactive to noise. So if you remember back, that's when I said, sometimes you'll hear the anesthesia provider saying quiet on deck. Because the patient may experience agitation or excitement during this phase. It is so important for us and the entire team to minimize noise and sudden movement during this time. The good thing is, once we reduce distractions, it does help prevent stress or any type of discomfort for the patient as they transition into anesthesia. With the maintenance phase, it starts once the patient's airway is secured and they are stable. It continues until the surgical procedure is completed. Anesthetic agents are given as needed, which is PRN, and that's just to maintain the patient's unconsciousness, comfort, and stability throughout the entire procedure. I talk about awareness during surgery. Some patients may recall or have explicit memories of events that occurred during surgery, which is known as interoperative awareness. As you can see from the slide, this occurs in about 20,000 to 40,000 cases each year here in the United States. There are risk factors that we have to take into consideration. Patients with a history of substance abuse or chronic pain are more likely to experience this. Us as STs and the team have to be aware of patients that may hear and remember conversations during surgery. We can no longer assume the patient is completely unaware. So it is important to maintain professionalism and avoid casual or inappropriate comments because of this reason. The chapter brings up long acting muscle relaxants, talking about the timing and the monitoring. Long acting muscle relaxants are given during the maintenance phase to keep the patient relaxed. This is where that maintenance comes in. Think about when you go to get your car tuned up. It's not that there's anything wrong with it, but you want to keep it kind of going smooth. Proper timing of muscle relaxing is so important to make sure the patient remains relaxed only as needed. The depth of muscle relaxation is checked with a peripheral nerve stimulator to ensure it is at the correct level. Again, this is not things that we're going to be directly involved with, but you will be quick to pick up on anesthesia cues. So, especially if you've worked with your team, which is your anesthesiologist, your surgeon, if you've worked with a certain team, after a while, you start to pick up different things. Okay. Now, muscle relaxants should last through the closure of the deep wound layers. It should start to wear off as we start moving up into the superficial layers or being closed. So start thinking fascia, skin layers, okay? We're starting to, the patient may start to come out. Anesthesia will pick up on cues from the surgeon. When, for example, certain cases when a doc is asking for a forearm monocryl or a monocryl at all, and we've already done our repair anesthesia, even as techs, we're like, oh, we're about to close. We're loading up those sutures and we'll know way before then. But that's a cue for anesthesia to start kind of pulling back some of that medication. Okay. The approach helps just to make sure the patient is, again, relaxed during the surgery, but able to recover function when needed. So now we get into the emergent phase. This begins at the end of the surgical procedure. Anesthetic agents are discontinued or allowed to kind of wear off. The patient starts to wake up. The airway is removed, extubated, as needed. And that's going to be PRN. The phase ends when the patient is safely transported to the PACU. And what was PACU again? Can someone tell me? If you guys remember what PACU stands for again? Anyone? Anyone? Especially if you've worked in a hospital. What? Post anesthesia care. That is correct. PACU is post anesthesia care. Now, some things to be aware of. During emergence, patients are highly reactive to noise and movement, right? So we, again, are just making sure that we're quiet and we're careful when we're cleaning up, minimizing noise and sudden movements to ensure a smoother recovery for a patient. And I want you to think of it this way. Have you ever been in a deep sleep or thought you were in a deep sleep and a loud noise woke you up? How did you feel? Okay. So when we kind of put ourselves into that mindset, we're like, okay. If we're making a lot of noise and everything, and knowing that we're bringing the patient out of anesthesia, just like we get that jolt, it could happen to them too. Again, the ET tube is removed, and this is when the patient is sufficiently awake and we're starting to look at how stable they are. Now, if needed, a mask is used just to provide oxygen to the patient. The anesthesia care provider gives a detailed report to the PACU staff nurses about what's going on with the patient's status. But there are some things to think about. The patient must be breathing on their own and able to maintain their airway independently before the ET tube is removed. So keep that in mind. And then we have the recovery phase. Okay. In the recovery phase, this starts when the patient is admitted to the post anesthesia care PACU, and the patient fully awakens from anesthesia and begins the recovery. The patient's vital signs, they have to be stable before they can be discharged from the PACU. Keep in mind that the recovery phase is the final post-operative phase of general anesthesia, focusing on the monitoring and ensuring the patient's safety as they regain full consciousness and stability. We look at intravenous induction agents, okay? They induce unconsciousness at the start of anesthesia. They also prevent the sensation of pain during the procedure, which is something that, of course, we want. Your inhalation agents induce unconsciousness and prevent motor responses to painful stimuli. And your neuromuscular blocking agents, which we're going to watch a quick video on, relax the muscles for intubation and help during the surgical procedure. So let's take a quick little look at this video.
Neuromuscular blocking agents are often used in anesthesia to help with an endotracheal intubation procedure or to prepare a patient for surgery. This is a class of medications that respiratory therapists and students must be familiar with, which is why we created this quick video to help. So, if you're ready, let's get into it. What are neuromuscular blocking agents? As we previously mentioned, these are a class of medications that cause paralysis of skeletal muscle tissues. They work by altering the action of the postsynaptic acetylcholine receptors. This causes paralysis of the muscles of respiration, which is why mechanical ventilation is required whenever a neuromuscular blocking agent has been administered. These drugs are often given to facilitate intubation and improve the surgical condition of preoperative patients. Keep in mind that these patients, while paralyzed, will still be fully aware. This is why analgesic and general anesthetics must be given as well along with neuromuscular blocking agents. So now let's talk about the different types of these drugs. In general, there are two types of neuromuscular blocking drugs: depolarizing agents and non-depolarizing agents. As the name suggests, depolarizing agents cause rapid depolarization, which makes the muscle fibers resistant to stimulation by acetylcholine. They provide a rapid onset and short duration that lasts only 7 to 12 minutes. An example of a depolarizing neuromuscular blocking agent is acetylcholine, or also known as anectine. Non-depolarizing agents, on the other hand, cause total paralysis by blocking the binding of acetylcholine and the inotropic activity of acetylcholine receptors. The onset of this type is rapid as the medication takes effect within minutes, although not as rapid as depolarizing agents that work in a matter of seconds. The duration is longer as well, lasting from 30 minutes up to 2 hours. Some examples of non-depolarizing neuromuscular blocking agents include the following. Rather than listing them all out, I'm just going to put them on the screen right now for you, so if you need to pause the video and take a look, just go right ahead and do that now. But another important tidbit to remember is that non-depolarizing agents can be reversed with anticholinesterase inhibitors. Again, we created this video just to provide you with a brief overview of this topic. We'll be breaking it down into much more detail in a separate video. Real quick guys, do me a huge favor and hit the like button. It really helps support the channel and I greatly appreciate it. And while you're down there, go ahead and click the subscribe button as well, because we have a ton of other videos on our channel that I think you will enjoy. Just a quick reminder, we are not doctors. This video is for educational and informational purposes only. And if you want to dive deeper and learn more about this topic, you can go to respiratorytherapyzone.com, where we have a ton of free study guides, practice questions, and other.
All right. I was like, how far should I let this go? So again, if you do want to get a little bit more information, respiratory therapy zone. Okay. And the last thing is reversal agents. They reverse or counteract the effects of other anesthetic agents just to assist in recovery. We mentioned intravenous induction agents. Some examples would be benzodiazepines like your Valiums, your Verseds, your Ativans. These are used to induce that calming or sedative effect, commonly for the induction of anesthesia. We have hypnotics or barbiturates, pentanol, methylthioxazole, and these induce unconsciousness by depressing the central nervous system. And then we have other hypnotic agents. Ketamine, we have Propofol, which is the one everyone was familiar with the Michael Jackson case. Now, Propofol is the most frequently used agent for induction. It has a milky white color, and patients with allergies to like soy or eggs should avoid propofol because these substances are part of the emulsion. Okay. Other things. So from 14.1, what you see are a comparison of opioids used for analgesia during general anesthesia. They can be natural or synthetic. And opioids are administered during the maintenance phase of anesthesia to prevent pain and to make sure that the patient remains comfortable throughout the procedure. Our inhalation agents. These are volatile agents and they're stored in the liquid form and then poured into the vaporizer. Anesthesia does this. Okay. I don't even know if I've seen some anesthesia techs, but this is not something that we would, even if we're helping out at the surgery center. My anesthesiologist or my CRNAs took care of that. But it's kind of good to know, they may say, hey, can you grab a bottle, knowing where it is in the anesthesia workroom. Okay. They are converted into gas, and then this is what the patient inhales. So we look at disadvantages. They can cause a decrease in heart function. There is a lack of postoperative analgesia, so they do not provide pain relief after surgery, requiring additional analgesics. Now, the choice of inhalation agent depends on factors such as solubility of the gas and, of course, the patient's cardiac output. For those neuromuscular blocking agents, here is a list on the screen. Now, these agents are used to relax skeletal muscle during intubation and throughout the entire surgical procedure, just to ensure that the patient remains immobile. Now, while the patient is under general anesthesia, they become pain-free, memory-free. Their skeletal muscles may still kind of respond to stimuli. So neuromuscular blockers prevents this by just relaxing all of those muscles. Now, for muscle contraction, stimulation from the motor nerve is required. So neuromuscular blockers they go in and they interrupt that process. We also have those reversal agents. So we went through everything, and now you can actually see them on the slide. Again, remember, these reversal agents are used to counteract the effects of specific anesthetic agents, especially when the surgical procedure, let's say, ends earlier than planned. The type of reversal agent depends on the agent that's being, of course, reversed. All right. Now, keep in mind that reversal agents are important because you want to help the patient recover from any type of anesthesia that they're going through, especially when you have a case that was scheduled for 4 hours and now you hear, hey, we're going to be closing in about 30 minutes, and you look up and the case has only been going on for 2 hours. That has happened. Okay. So now anesthesia is going to pull out one of these reversal agents because the case went faster than desired. Before we get into our Kahoot and our time for our survey, here's another question from that mini session. Which of the following is the first and most reliable sign of malignant hypothermia that healthcare providers should monitor for during anesthesia? And this is extremely important. Is it tachypnea, rapid breathing, or B, increase in end-tidal CO2? A or B? I see one person with the correct answer already. I have two people that answered. One is correct. Three have answered. One is correct. Okay, four. All right, so let's break this down. I'm going to start off with the incorrect answer first and break it down. Okay, so anyone who chose option A, that is incorrect, but let me tell you why. Now, tachypnea, which is rapid breathing, it is a sign of MH, so that is correct. It occurs as the body attempts to eliminate excess CO2, which is a secondary response. The increase in end-tidal CO2 is primary and most reliable sign of malignant hypothermia, making it more critical as an earlier indicator than tachypnea, because by the time they got to tachypnea, they could potentially already be in a malignant hypothermia episode. Okay. But this is one of those questions where you're like, okay, they're both signs, but which one is going to be that initial indicator? And the answer is increase in tidal CO2, just in case you see that question or a concept of that question. Oh, okay, I got you. Um, and then the second question, still dealing with malignant hypothermia, because this is a true medical emergency that could happen in the operating room. And this is one of those cases where sometimes patients don't know they have malignant hypothermia until we all find out. Okay. So, which of the following is a key role of the ST during the malignant hypothermia, the management of malignant hypothermia? Is it A, administering dantrolene to reverse the effects of MH, or B, assisting with oxygen administration, cooling the patient, and preparing medications for the team? I've got one correct answer so far, two correct answers so far, three. Keep coming, you guys. It's A or B. A or B. What do you think? Okay. Dun, 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 dun. Let's go with the correct answer this time. So, in this case, option B is actually correct. But again, I'm going to break it down. Because our role in the management of malignant hypothermia involves assisting with oxygen administration, helping cool the patient using, let's say, ice packs or other methods, and preparing, let's say, necessary medications for the anesthesia team. We just have to be familiar with the emergency medications and equipment to act quickly and support the team in managing this extremely critical condition. And the reason why it's not dantrolene is the correct medication, but it falls on the responsibility of the anesthesia team, not us as surgical techs. So, of course, I'm going to keep breaking it down. All right. If you have taken your survey, you have a 5-minute break. If you have not taken your survey yet, let me give you the link to share your thoughts. Remember, like I said on Monday, we cannot fix something that we don't know is broke. And our goal is to continuously improve the program because we want you guys to be the best and we want you to feel the best as you go off to your different careers. So I am going to set my timer. For those of you who have taken it already, go ahead and take a 5-minute break and we will all be back in about 5 minutes. Okay. What questions do you have for me? Because I have a few for you. If you are able to join, go ahead. I think we need at least 2 individuals to join. There are 6 of us here. If you are not able to join, I'm going to ask you just to kind of type in your answer in the chat, okay? And that account for your participation as well. I like the new little name thingies. It's really cute. We're going to give a couple more minutes for one to join. There are 10 questions. And for the true or false, I kept them at 10 seconds. And then the multiple choice back to 20. Okay. So we'll see how that works. All right. So of the 6 of us, 5 of us are in. Again, if you have not been able to join in, I just ask you can type in your response in the chat. Okay. Let me do something really quick. Okay, perfect. Let's start. There we go. That is correct. Yes. The answer is true. It looks like that one did go to 3. Sorry, guys. It looks like or, oh no, we're good. We're good. Okay. I will be sharing this with you guys too, so that way you can get a little bit more practice. Fluminazole. It is true. Next question. So this is the one where we're talking about that cardiac, okay? Cardiovascular depression. Question 8. It is false. And that was a 50-50. This is used to reverse the effects of benzodiazepines, not non-depolarizing muscle relaxants, okay? Sucks. That's what we call succinylcholine, but you'll hear it normally as sucks. And the last question. And that is true. Naloxone Narcan is a reversal agent for opioids. Good job, everyone. Good job, everyone. All right, I know we're getting closer and closer to the finish line. We can almost feel it. It's right there. So, what did we cover? Let me make sure I turn this off. Hold on, guys, because it's going to continue to play in the background. All right. We covered key aspects of general anesthesia, including the phases of anesthesia, kind of broke those down: pre-induction, induction, maintenance, emergence, and recovery. That leads us to know that there are 5 phases of anesthesia. You may see that. They can throw that concept in a lot of different ways. The different types of anesthesia agents, from IV, inhalation, neuromuscular blockers, and their specific roles in surgical procedures. We talked about the importance of just watching our patients, the use of reversal agents, and minimizing noise during the critical phases like emergence. We also explored common anesthetic agents like propofol, opioids, nitrous oxide, as well as just different risks associated with anesthesia, like awareness being under anesthesia. For those of you that are watching this playback, I have some questions for you. How do the properties of inhalation versus intravenous anesthetics affect anesthesia management? What are the steps that we as surgical techs can take to prevent awareness under anesthesia? And how could improvements of neuromuscular blockers benefit high-risk patients? With that, you guys, I just want to thank you all for being here. Please have a wonderful rest of your evening, a great rest of your week. Be safe, and I look forward to seeing everyone who can attend our review for ST 300. Also, if you haven't finished your survey, make sure to knock it out. Let us know how we're doing. With that, good night, everyone.